What is rehab or rehabilitation? My name is Fred Begaris, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. So I just had a really good conversation with a referring doc the other day that I just had to share. They've referred a patient for an EMG of the left leg with symptoms predominantly of numbness. And whenever I receive a referral for an EMG or a nerve conduction study, I like to talk to the patient ahead of time and review their records, but also give them a heads up regarding the EMG study. It is notoriously not a very comfortable or fun test. I personally describe it as annoying, but I wanted to make sure that the patient was prepared, not just for the test, but also to talk to them about their goals, get a little bit about their history. And obviously, I wanted to make sure that I can answer their questions, but also the questions of the referring doc. That being said, that's actually, I think, something that's missing. As a side note, that oftentimes I get a referral for an EMG study, which is asking a very particular question, and the patient's question coming into the visit is different. So I wanted to make sure that I was very clear about what the test can explain prior to the study, but also essentially set expectations for everybody. In the discussions, I figured out that it sounds like this particular person has something called lateral femoral cutaneous neuralgia or Meralgia Parasthetica, at least by history. So they ended up coming in, and then when I did my physical examination, it seemed to match this diagnosis. So as opposed to doing the nerve study, which is the main reason they were referred to me, after talking with the patient and making a formal diagnosis, I decided to just do a regular consultation. So interestingly, the patient was going to see a hand surgeon in the next couple of weeks because they were having hand numbness, which was something completely separate. But they had mentioned this to the referring doc, and they were sent to see a hand surgeon. So, long story short, I talked to the patient, explained everything. They were on board with doing the consultation, did the nerve study, generated the report, and then I sent it back to the primary care doc. But because what I did was so different from the initial referral, I felt like I should explain myself to them, at least my rationale as to why I did what I did. So I was able to call them. Unfortunately, I had to go through the same phone tree that everybody does. I left a voicemail, and I got a call back in about a day and a half. And, essentially, the doc was very nice, very gracious, and we had a great conversation. But the highlights were I wanted to make sure that they understood why I did what I did. Now, the referral was for the thigh numbness. I had the opportunity to review the notes, see an MRI, but more importantly, do physical examination with ultrasound evaluation. And I explained to them that nerve conduction study for Meralgia Parasthetica can definitely fall short in a couple of different ways. From a technical and operator standpoint, it is a nerve that sometimes is difficult to study. As a bottom line, there's various factors that go into it. There's a lot of artifact, but at the end of the day, sometimes the nerve is hard to study and you cannot necessarily conclude anything. Now, on the occasion, I have had a good waveform, but that doesn't necessarily help make the clinical diagnosis either, because The presence or absence doesn't necessarily rule in or out that Meralgia Parasthetica is the main problem, or at least completely. Sometimes you have to do a diagnostic block to couple it with a physical examination. And so I wanted to make sure that the doc understood, like, hey, this is not typical nerve study where it's black and white. Other conditions can be black and white, but Meralgia Parasthetica often has a normal study, and the diagnosis is made with a different test or an injection. So um, they seem to understand that, but I also looped in, my rationale for doing the nurse study ahead of time, of them seeing their hand specialist. So they obviously were referred for, hand symptoms, pain, numbness. And rather than have the hand surgeon see them and then request the nurse study, I decided to just do it the same day, anyways. And overall, they were very appreciative because essentially I answered all of the questions from the patient standpoint, from the referring doc standpoint, and from future consultation standpoint. And they again were appreciative, but more importantly, I wanted to, talk with them not just from a clinician standpoint of communicating my rationale, but even just as a relationship. I think a large reason why I have established the practice that I have is because it was no longer relationship based. Unfortunately, in an insurance based model, it's very transactional. So, I have to reestablish my relationships or create relationships with my patients. Um, Similarly, I have to establish these relationships with referring docs in my area. Um, I wanted to let them know my particular style and essentially know that no matter what you send to my clinic, that I will do what is best for your patient. That means, doing not just doing the study, but explaining it to them. And unfortunately, that has, in my experience, has not always been welcomed. Some physicians welcome my input. Some people just want me to be a straight technician, just do the study, and then essentially keep my mouth shut and kick them out. And you know, that's not to say that's right or wrong, but that's definitely not my particular style of practice. I just never really felt comfortable doing a study, and naturally, as a patient, you're going to say, "Well, can you give me any clues?" And essentially, if you're going to be the technician, you can't say anything, or you shouldn't say anything, and you just refer them back to their referring doc to explain the study. And I don't know, just never really sat well with me. Like, I'm clearly qualified to interpret the results. I'm going to share it. But some physicians in the past do not like that. They want me to essentially just do the study and keep my opinions to myself. Again, not my particular style. Nothing against that, but you know, part of me discussing this with referring docs is to let them know that this is my particular style, and if they want a different or lesser level of care, they can refer their patients, to another doc. But that's just not something I'm willing to do. But in addition to that, my final thought is that this particular set of symptoms, thigh numbness, doesn't is not very clear, and often needs a lot of different referrals. So um, the common story is a patient will go to their primary care doctor with a history of thigh numbness. They get sent to physical therapy. The numbness does not improve. They get an MRI of the lumbar spine. The MRI of the lumbar spine is inconclusive or shows some very, very mild or degenerative changes, which may or may not be the actual cause. They get referred for the EMG study, which comes back normal. So after that, they get sent to see the spine surgeon. The spine surgeon concludes that this is a non-surgical issue and that it's not, they may or may not weigh in that this is actually a radicular problem. But oftentimes they end up being referred to see a pain specialist for potential interventional spine injections. So as a patient, that's a lot of visits. That's a lot of copays, a lot of time off, a lot of waiting room time to have essentially no no real answer. And I'm again, I was very happy with the level of care I provided. I saved a lot of time and frustration for all parties involved, and just answer the questions as best as I could. And it didn't take me that long. Now, obviously, my practice is different. I've set it up in a way that I can answer these questions. I can give patients the allotted amount of time. I can ensure that the reports get there. Ironically, I sent this report the same day, and even after a couple days passing, I was able to confirm with the referring doc that the report was not in the system. So I refaxed it, and again, it's just another touch point that we need to make sure that our work is actually received. So um I was just really very happy with the work that I did, and I wanted to share my thoughts on this particular case, because um I the big reason why I changed my career and created the practice that I now love is because I was not happy with the way that I was practicing. And it just felt really good. I think that's all I can say. And for anyone that's listening, either patients or physicians, please know that this level of care is out there. It may not be common, but it is out there. So keep looking. Thanks again for listening. Take care. Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.